Mix, match and manage. The triple M of mitomycin C. Scarring at the surgical site is the most common cause of failure of trabeculectomy. Antimetabolites like mitomycin essentially freeze the scarring process. The concentration of mitomycin C used in trabeculectomy can influence blood filtration and intraocular pressure. High risk for failure of trabeculectomy include neovascular glaucoma, uveitis, previous failed filtration surgeries, aphakia, and patients of Afro-Caribbean origin. Hence, it is essential to modulate the dosage, timing, and application of mitomycin C. This varies from surgeon to surgeon, which tends to create a dilemma for budding surgeons. Literature provides dosage in varying units ranging from milligram, microgram to percentages, which further adds to the confusion. By the end of this video, we hope to clear the confusion. In this video, we demonstrate the reconstitution of mitomycin C in two dosages, 0.2 mg per ml and 0.4 mg per ml, and its application. Mitomycin C is available as a 2 mg powder form. It should be reconstituted using sterile water at a neutral pH. To get 0.2 mg per ml, 10 ml of sterile water is mixed with 2 mg powder. To get 0.4 mg per ml, 5 ml of sterile water is mixed with 2 mg powder. For subconjunctival injection, 0.1 ml of either of these reconstituted solutions are mixed with 0.1 ml of lignocaine. Thus, we get a concentration of 0.02 mg or 20 microgram when we use the 0.2 mg per ml solution and a concentration of 0.04 mg or 40 microgram when we use the 0.4 mg per ml solution. Subconjunctival injection with superior rectus bridle suture. A 30 gauge needle is introduced on either side of the bridle suture. Care should be taken not to damage the rectus muscle. To avoid migration to the limbus, the drug is swiped posteriorly. Subconjunctival injection in the presence of corneal traction suture. Here, adequate traction is provided using corneal traction suture and the needle is introduced 7 to 8 mm posterior to the limbus. The mitomycin preparation is injected posterior to the anticipated flap location. The most commonly used method of applying mitomycin is to soak a Weck cell sponge in the reconstituted solution. Apply the sponge to the ocular tissues for a few minutes and copiously irrigate it with saline. Compared to the sponges, the injections use a lower lignocaine diluted concentration. Drawbacks of sponge application. It can cause a whitish mitomycin C burn, often due to overdosing. This further increases the risk of leak and infection. Insufficiently treated area may cause premature scar formation. There is always a risk of losing or retaining sponge. Most often, it is difficult to know the exact amount of drug delivered. There has been reports of leftover mitomycin C sponge causing phlebitis. The incidence of bleb-related infections has been reported to 0.55% for phlebitis and 0.45% to 1.3% for bleb-associated endophthalmitis. Various devices like scleral shield, methyl cellulose sponges, gel foam discs are available to deliver antimetabolite agents. While using these, fine particles of lint may get dislodged and stay at the site, leading to inflammation and bleb failure. Sponges may be lost due to deeper insertion. Retained sponges can lead to conjunctival holes, granulomas, and cause infection. So, prompt surgical removal of the retained sponge is needed. Literature describes various methods to avoid sponge retention, like counting the sponges, thorough irrigation, and inspection of the subconjunctival space. Also, check for the intactness of the sponge before inserting and after removing. Polyvinyl alcohol microsurgical sponge can be used as its cut pieces do not leave behind any microfragments when soaked with antimetabolites. In order to avoid retention of sponges or losing sponges, they can be stained with trypan blue before insertion. To summarize, injections allow a larger treatment area and gives precise control on the amount of the drug delivered. It also helps to reduce surgical time and eliminate sponge retention worries. While sponges remain the most popular and time-tested conventional method, it might be easier for novice surgeons. Subconjunctival injection of mitomycin C is being used most commonly now with comparable surgical outcomes and no increase in complications. Studies have shown comparable surgical outcomes with similar postoperative intraocular pressures. A higher dose of mitomycin C is used in patients with high risk of scarring or fibrosis in cases of repeat trabeculectomy, failing blebs, and blood needling procedures. To conclude, awareness of proper reconstitution and accurate technique of mitomycin C application will help the novice glaucoma surgeons to achieve better outcomes during trabeculectomies.